My name is Brianna Verts, and this is my mini study analysis table presentation. My topic question is, are depleted iron stores or low ferritin a cause for negative pregnancy and neonatal outcomes? My reason for selecting this topic is clinically I've seen most women coming back with a really low ferritin number. Some women aren't being tested by certain midwives because they say everybody's coming back low, so what's the point? And then I haven't seen a long-term supplementation of iron recommended for those with low ferritin. I also have noticed that a couple different labs have different ranges of normal. So someone might test really low on one test and then have the exact same outcomes in another test, but because they have different ranges that are considered normal, you can be labeled normal without any issues even when it is low. And then I've also had personal experience with this, trying to get to the bottom of why I felt so dizzy and fatigued. I had a normal hemoglobin, but then come to find out after advocating for ferritin testing, that was a big cause of my symptoms. Studies I'm reviewing, the first one is analysis on the iron status and associated factors during the first trimester of pregnancy. This study was done in Beijing, so I will not try to pronounce that. The next study is maternal first trimester iron status and its association with obstetric and perinatal outcomes. This was by the Archives of Gynecology and Obstetrics. And the final study I'm reviewing is serum ferritin level is inversely related to number of previous pregnancy losses in women with recurrent pregnancy loss, and this was fertility and sterility. The study designs and results. The first study was a cross-sectional study using statistical analysis, principal component analysis for data collection, a two-sided Fisher probability test, and a one-way ANOVA for assessing iron status. The results for this study was 32.2% were iron deficient, 27.6% were iron depleted, 2.1% were iron deficient enteropiosis, and 1.5% were iron deficient anemic. Multiparity and young age were determined to be a risk factor for iron deficiency in the first trimester, which could have been prevented with iron supplements based on this study. The next study was a prospective cohort study separating groups and comparing data using a multivariable logistic regression. Iron supplementation impacts were studied by group-wise comparisons, and the results of this study was iron deficiency with anemia was associated with a higher risk of gestational diabetes, and iron deficiency without anemia was associated with stillbirth. Despite supplementation for 4 weeks, 15.4% still remained iron deficient. And then the final study was a cohort study, and the results of this study was recurrent pregnancy loss group had a lower serum than the comparison group. It was 39.9 versus 62.2, and a higher risk of low iron stores, 35.7% versus 13.7%. And ferritin levels were not a reliable predictor for pregnancy loss after recurrent pregnancy loss. Weaknesses of these studies, the first one did not address risks that were associated with the depleted iron. It just assessed risk factors for being depleted in the first place. The next study, weaknesses, was only one risk was identified with each of the iron deficient groups. It was a short-term iron supplementation that was conducted of only 4 weeks. And the weakness of the final study was it was a smaller sample size than other studies. It also didn't determine if supplementation prevented miscarriage. The strengths of the first study was it addressed those who were at risk of being iron deficient during pregnancy, which could help prevent pregnancy complications from developing. And it also supported the theory that iron supplementation could be the corrective factor for the deficiency. The strengths of the second study was it was a large group done with over 5,000 women. Risks were identified with low iron stores with and without anemia. And strengths of the final study was it showed the connection between miscarriages and low iron stores.